Alveolar macrophages originate from circulating monocytes produced in the bone marrow. Alveolar macrophages migrate to the lungs through the bloodstream. In the context of the tumor microenvironment, TME, alveolar macrophages undergo distinct subunit activation. The TME influences their functions, and the interplay involves various cytokines. We look at the classically activated macrophage, or we call as M1. M1 is stimulated by the factors like interferon gamma, IFNG, and lipopolysaccharide, LPS. The M1 subunit can be characterized by the release of interleukin 1, 6, 12, tumor necrosis factor alpha, and inducible nitric oxide synthase. This is an example of pro-inflammatory cytokines that inhibit the tumor progression or eliminate the cancer cells. The second subunit is alternatively activated macrophage, or M2. For M2, it's divided into three types: M2A that triggered by interleukin 4 and interleukin 13, M2B triggered by interleukin 1R and toll-like receptor, and M2C is triggered by interleukin 10 and transforming growth factor beta. This are type of anti-inflammatory cytokine, and it promotes the tissue repair, angiogenesis, which help for tumor growth or tumor progression. Let's take a look for classically activated macrophage, or M1. Before we go any further, we need to bear in mind that a tumor cell is what we call a manipulator. It manipulates the immune response and the production of cytokines to its advantage, creating an environment known as immunosuppressive microenvironment that allows it to evade immune detection and destruction. So, a tumor cell will release factors that modulate cytokine production and cause altered cytotoxicity and cytokine release. A normal person typically has detectable levels of IL-1, IL-6, and tumor necrosis factor alpha, TNF-alpha, but in optimum level. They are not absent in healthy individuals. However, in the context of tumors, the levels and activities of these pro-inflammatory cytokines can be dysregulated. IL-1 is an anti-tumor that normally helps regulating the inflammatory response in the lungs and coordinate the immune response. However, IL-1 can contribute to tumor progression by promoting inflammation and supporting angiogenesis. This inflammation can create an environment that supports the growth of cancer cells. As for angiogenesis, imagine a tumor as a growing city. For it to get bigger, it needs more roads, in this case, blood vessels, to bring in supplies like nutrients and oxygen. So, IL-1 can signal the body to build these new roads through a process called angiogenesis, helping the tumor get what it needs to grow. IL-6, also an anti-tumor, that involved in coordinating immune responses in the lungs. It also activates immune cells and contributes to the regulation of inflammation. However, in presence of tumor, IL-6 can contribute to the development of an immunosuppressive environment, enabling tumors to evade the immune system. Elevated levels of IL-6 are often observed in various cancers, and this increase is linked to more aggressive tumor behavior. TNF-alpha is a potent pro-inflammatory cytokine that induces inflammation in the lungs, playing a crucial role in the early stages of the immune response. In tumor progression, TNF-alpha can have dual effects. It may promote inflammation, which can aid tumor growth, but it also has anti-tumor effects that induce cell death. While it might be elevated in some cases, the specific impact can depend on the tumor type and the context of the immune response. We can also find reduced production of IL-1, IL-6, and TNF-alpha in lung cancer. This is commonly demonstrated in alveolar macrophages from patients with non-small cell lung cancer and small cell lung cancer. Reduced IL-6 secretion is also derived from patients with specific subtypes of lung cancer. Normally, TNF-alpha, IL-1, and IL-6 typically promote the induction of Th1, T helper cells, which are crucial for macrophage-mediated killing. However, in cases of decreased cytokine production, it may limit the cytotoxic potential of alveolar macrophages or tumor-associated macrophages, TAMs. This limitation can enable tumor progression by compromising macrophage-mediated killing, contributing to the complex interplay between immune responses and lung cancer development. Now, we continue with alternatively activated macrophage, or M2. In lung cancer patient, the higher content of interleukin 10 will alter the function of Golgi apparatus and rough endoplasmic reticulum, RER, of the alveolar macrophages. What happened next? Impaired function of Golgi apparatus and RER will decrease the secretion of cytokines. Next, It will reduce the cytostatic activity of alveolar macrophage, and the tumor growth and proliferation will elevated. This is the amount of IL-10 and TGF-beta in normal people and lung cancer patient. So we look at the IL-10 first. Basically, IL-10 in the lungs serves as a key regulator of immune responses, exerting anti-inflammatory effects to suppress excessive inflammation and maintain immune homeostasis. It plays a role in tissue repair and remodeling, contributing to the resolution of inflammation. However, in the presence of tumors, the levels and activities of interleukin-10, IL-10, can be altered. Tumors often exploit IL-10 to create an immunosuppressive microenvironment by inhibiting the activity of immune cells, particularly T cells, which play a crucial role in recognizing and eliminating cancer cells, thus aiding the tumors in evading the immune system. IL-10 acts by suppressing the activity of immune cells, such as cytotoxic T cells and natural killer cells. This inhibition hinders the body's ability to mount an effective immune response against the tumor. So, tumors can exploit these cytokines to induce immune tolerance, essentially tricking the immune system into not recognizing them as threats. This strategy helps the tumor cells evade detection and destruction. For TGF-beta, the increasing amount of it in the lung cancer can contribute to immunosuppression, allowing tumors to evade the immune system. When there is no process of immune system, then there is no process of tumor inhibition will happen. Normally, AMs will take up antigens for processing and present them on major histocompatibility complex, MHC classes, 1 and 2 molecules. This activates T cells and in turn stimulates phagocytosis, macrophage-mediated killing, and the release of pro-inflammatory cytokines, TNF-alpha and IL-1. However, altered phagocytic capacity and receptor expression occurs. A study found that AMs from patients with small cell and squamous cell carcinoma were impaired in their ability to uptake 40 nm fluorescent polystyrene beads, while AMs from patients with small cell, squamous, and large undifferentiated carcinoma showed impaired uptake of 1,000 nm beads. Impairment of uptake ability may highlight impairment in the phagocytic ability of AMs in lung cancer. This study suggested differences in the phagocytic ability of AMs depending upon histological subtype of lung cancer. Reduced functionality of AMs also may promote tumor growth and differentiation. Altered cell surface expression of MHC molecules on AMs has been found in patients with lung cancer. Decreased MHC class 2 expression on AMs from patients with small cell carcinoma and decreased intracellular adhesion molecule, ICAM1, and CD83 expression from patients with small, large, and squamous cell carcinoma after IFN gamma stimulation have been demonstrated by flow cytometry. Conversely, McDonald and Atkins found no difference in the expression of ICAM1 with or without IFN gamma stimulation. ICAM1 plays an important role in the early stages of T-cell activation. Reduced expression of ICAM1 therefore impairs AM-mediated cytotoxicity. In addition, reduced expression of mannose receptor by AMs in lung cancer patients has also been shown. Therefore, reduced receptor expression may impair anti-tumor function by AMs and favor tumor progression. That's all from us. Thank you for listening.